I'm Dr. Larry Dean, the Director of the University of Washington Regional Heart Center. I'd like to welcome all of you to our Regional Heart Center Grand Rounds this morning. It's a pleasure for me to be able to introduce our first presenter, Dr. Philip Massey, who's a member of the Division of Cardiology at the University of Washington School of Medicine. Dr. Massey.
Thank you, Dr. Dean. This case is a 68-year-old man with a history of recurrent and worsening chest pain with exertion and at rest over the previous 4 days. The patient had a prolonged episode of chest pain while flying cross-country. The patient's history is significant for coronary artery bypass graft surgery 18 years ago. 2 months previous to this presentation, the patient had stenting done elsewhere of a saphenous vein graft to diagonal anastomosis and also stenting of a proximal and mid-circumflex coronary artery. The patient's other past medical history is significant for carotid endarterectomy and hypertension. The patient's medications are aspirin, amlodipine, clopidogrel, ramipril, atorvastatin, labetalol, niacin, and as-needed Viagra. The patient's physical exam, blood pressure 140/60, heart rate of 70. The rest of the exam was unremarkable. The patient's labs were significant for an elevated troponin of 5.9. The electrocardiogram at presentation is seen here. We can see first-degree AV block as well as nonspecific T-wave changes noted laterally. Management, the patient was started on enoxaparin and tirofiban and continued on his previous cardiac medications. An echocardiogram was obtained. This revealed akinesis of the anterior septal wall and septum with preserved ejection fraction of 57%. A cardiac catheterization was then performed. This revealed an occluded right coronary artery and left anterior descending artery. There was a patent vein graft to the diagonal artery. However, the skip portion of this graft to the LAD was occluded. There was 60% in-stent restenosis in this vein graft. The vein graft to the posterior descending artery was patent, and the circumflex artery was noted to be diffusely diseased with severe in-stent restenosis, and the graft to the circumflex was occluded. This is our angiogram of the left coronary artery. Here we can see a significantly stenotic circumflex artery. This artery has been stented. The location of the stents are approximately from here to here. We can also see distally TIMI grade 2 flow. The location of the LAD would have been here if it were not occluded. However, the LAD is proximally occluded and thus it is not seen. On this next frame, we have a still frame of the circumflex artery revealing the stented portion of the vessel, and we also see diffuse in-stent restenosis along this portion. This other arrow points to where the left anterior descending artery would have been visualized if it were not occluded. This next angiogram is of the saphenous vein graft to the posterior descending artery, which is widely patent. On this still frame of the distal portion of the posterior descending artery, although it's somewhat difficult to appreciate on this reproduction, collaterals to septal perforators and to a tiny left anterior descending artery could be visualized on the original film. This next angiogram is of the saphenous vein graft to the diagonal artery, and we can appreciate a moderate stenosis at the anastomotic portion here. Let me show you a still frame of this. Here we can see these arrows that point to the stented portion of this vessel and a moderate stenosis at the anastomosis. In order to further define the degree of stenosis there, intravascular ultrasound was performed. Here we can see our intravascular ultrasound catheter, and the bright spots on the outside represent the stented portion of the vessel. Inside this, we can see echolucent material, which represents tissue in the lumen of the vessel. A close-up of this reveals the outline of the lumen, which had an area of 3 millimeters squared, which is below our cutoff of 4 millimeters squared for significant obstruction. Dr. Larry Dean will now discuss the management of coronary restenosis.
Thank you, Dr. Massey. The title of my discussion this morning will be Coronary Restenosis, Is It Still the Achilles Heel of PTCA? But before I get into the discussion, I'd like to point out that this patient's had several different therapies already rendered, including bypass surgery and percutaneous intervention, both of which have had difficulty or failed over the years that he has been bypassed. But before I get into the discussion of my topic today, I'd like to introduce Dr. Alec Clues, a professor of surgery and vice chairman for research and development, who will discuss briefly the healing response to vessel injury. Dr. Clues.
Thank you, Larry. We'll get started. What I want to do is to review with you just very briefly the biology of vascular injury and repair, because if we go backwards one slide, one of the hallmarks of all forms of vascular reconstruction is that it leads to this vicious cycle where the reconstruction, which is designed to restore the lumen, leads to injury. The injury induces an arterial response, and this leads to scar tissue and re-narrowing of the blood vessel, which gets you back to where you were at the outset. And this patient perfectly exemplifies this problem. Now, the studies that have been done in the laboratory to find out more about the process of injury have been conducted largely in the rat, although in other animals as well, where a catheter is just passed into the carotid artery of the rat, and it causes injury by scraping off the inner lining of the wall. What happens is that the artery, which you see here, over a period of days becomes much thicker. You can appreciate that it goes from here to here over a period of 3 months. And this is very typical, and it's very typical in humans as well. Here's an example of this intimal hyperplasia where the stents were placed at this time, and over a period of a month, this lesion formed. All this is new tissue that is formed, and the corresponding angiographic appearance is shown up here. Looks wide open here. You see narrowing here. You saw similar pictures just a moment ago. What drives the process? Well, the initial injury does two things. It scrapes off the inner lining of cells and causes platelets to adhere to the surface and creates a thrombus. This thrombus contains within it factors that mobilize the cells in the wall to migrate into the zone of injury. In addition, the injury itself causes the cells in the wall to become disrupted and release factors that act on the neighboring cells. The sum total, and it's shown in very simplistic form, is to recruit cells into the zone of injury and induce them to proliferate. Now, it's important to point out that not only is the process of activating cells into the proliferative and migratory state conducted by growth factors, but it's also, and in parallel, stimulated by the removal of factors that inhibit growth and inhibit migration. And it is in this area that we've had some luck, and I think that Dr. Dean will be going over this in more detail, but many of the drugs that are currently being used act on the cell cycle. Here it is shown in schematic form. The cells in the wall live in the resting state. They are activated by the injury process. They get into the cycle and replicate. And the drugs that are now being used act on various phases of this cycle to retard growth. Dr. Dean?
Thank you, Dr. Clues. I have a similar slide. Most of my presentation will be of the clinical approach to the treatment of in-stent restenosis or even restenosis following routine angioplasty. This is a slide from the literature. The interesting parts of this slide are that this is the result that you have with standard balloon angioplasty, where you've had injury to the deep portions of the media and also injury obviously to the overlying endothelium, all of which bring about two particular problems. One is acute vessel closure, which we're not going to discuss today, and the second is the exposure of the subendothelial layer to those things that produce restenosis following balloon angioplasty. So coronary restenosis has taken us now several years to sort through the various mechanisms responsible for coronary restenosis following angioplasty. There are mechanical properties of the vessel, including elastic recoil, in which the vessel after angioplasty will actually, because of its elasticity, re-narrow. There's also what's been called negative remodeling, which is a healing process that occurs after balloon angioplasty, in which scar tissue being formed actually causes constriction of the vessel over a period of months. And then there are biological issues, as Dr. Clues has pointed out quite nicely, including smooth muscle cell migration, proliferation, and extracellular matrix formation, which occurs again over several months following injury from balloon angioplasty. Usually balloon angioplasty clinically, if we see restenosis occurs in the first 6 months. The median time to restenosis is about 2 to 3 months following routine balloon angioplasty, or as it's been termed, POBA, plain old balloon angioplasty. We've tried various mechanisms of treating vessels, all designed to try to decrease the problem of restenosis. And this is sort of a cartoon showing the various approaches that we have had to the problem of restenosis. But I think, as pointed out by Dr. Clues, now that we have been able to solve some of the mechanical problems with the use of coronary stents, for example, we still have the biology to take care of, and that's the reason we continue to see restenosis with our current techniques. But on this slide, again, various techniques, including stents, which are primarily used today, and then also, as I believe was used in this patient, to which Dr. Goldberg will subsequently discuss, cutting balloon. What do coronary stents do from the standpoint of having an impact on restenosis rates? Well, they maximize the geometric result. In other words, you cannot get the same kind of result, and I'll show some examples of this, with balloon angioplasty that you get with a coronary stent procedure. They eliminate elastic recoil. In other words, it's a mechanical device. The vessel can no longer recoil because of the mechanical support that's supplied by the coronary stent. They therefore also eliminate negative remodeling. The vessel cannot contract as scar tissue forms, but they actually do promote smooth muscle cell proliferation because of the effect that they have on the geometry and the elimination of elastic recoil and negative remodeling. They really overwhelm the increased smooth muscle cell proliferation that's seen with coronary stents. So they have had an impact on subsequent restenosis following balloon angioplasty. This is a slide looking at the effect of elastic recoil. This is from data in South America from Alfredo Rodriguez, which he took patients back to the catheterization laboratory following routine balloon angioplasty. Those that had recoil of the vessel, he then randomized to either stenting or continued medical therapy. And those who had continued medical therapy had a very high restenosis rate approaching 80%, versus those who had a stent placed in the 20% range. It's important to point out that although there's a tremendous impact in this high-risk patient population, this number still is not zero. So stents do not completely eliminate restenosis. A seminal trial, there are several in the literature. This is the STRESS trial, and I don't have time because of the limitations today to go over all those trials, but this is the STRESS trial. And just to call your attention to the bottom line, there's approximately a 30% reduction in this trial where patients were randomized to receive either balloon angioplasty or a coronary stent, where the restenosis rate in follow-up is classically defined angiographically was 42% in the control arm and about 32% in those who had a stent placed. Again, a significant impact on restenosis, but the restenosis rate is not zero. So this is another example similar to what Dr. Clues showed earlier, where a stent's been placed. These are the stent struts in this porcine artery. And then following in this particular case, several days, approximately 1 month, there's been a tremendous increase in the proliferative response due to the injury of placing the stent, so that we now have compromise of the lumen following coronary stenting in the animal. There are several factors that have an impact on restenosis following coronary stenting. And just to show one of those factors, it has to do not only with the length of stents placed, the type of lesion that is present to begin with, the length of the lesion, and several other factors. It also has to do to a great extent on what type of restenotic process that you see in the stent. So if you have a situation where the restenotic portion is very focal, then the chance of restenosis is quite low. However, if you have a stent that's completely occluded and you're successful in opening that back up, then your restenosis rates approach 80%. So this has a profound impact on subsequent restenosis, just the lesion itself that is seen at the time of repeat angiography. I think it's fair to say in the patient that's been presented so far that we have diffuse in-stent restenosis, which places that patient at significant risk for subsequent restenosis. Well, turning our attention to what we can potentially do at this point, commercially available currently is radiation therapy. Now, the idea behind this is, since this is an injury, this is wound healing. If you have over-exuberant wound healing, there's data in the literature from the standpoint of dermatology, for example, with keloids, where radiation therapy does have an impact on subsequent healing. And so the idea here is, can you inhibit healing to the point where you allow healing to occur, but not to the point where you produce restenosis? Again, in an animal model without radiation therapy versus with radiation therapy, showing a very clean luminous animal model of restenosis. This is one of the first trials to look at this whole issue. This is the SCRIPPS trial done in California. The importance behind this trial is it is in a small group of patients, approximately 52 patients who are randomized between radiation treatment and just balloon angioplasty or other therapies. It was a high-risk group of patients to begin with, and they used gamma radiation in this particular instance. Gamma radiation has its own set of issues which we don't have time to go into, but the bottom line here is that if you look at the patients who were treated with a radium-192, a gamma emitter, there was a significant decrease in the restenosis rate from about 54% in this high-risk group of patients down to approximately 17% with treatment. The START trial, another trial looking at radiation treatment, one of several. This uses beta radiation, which is a much more friendly type of radioactive source to use. This is strontium-90, which is a beta emitter, as I mentioned. And this looks at the angiographic follow-up in restenosis at 8 months following treatment. This is in in-stent restenosis patients. As you can see, if you look at the stented area, there's a significant decrease in the subsequent restenosis rate angiographically from about 41% down to 14%. It's important to note that there are some issues with respect to radiation treatment and restenosis, but again, I point out the fact that this number is not zero, so there still is in-stent restenosis following even radiation treatment. So we have not to date cured this particular problem. Now, as Dr. Clues alluded to, there are several drugs that are currently being looked at actively. Rapamycin or Sirolimus is one, paclitaxel or Taxol is another, actinomycin D. There's several that will be coming along in the next few years. The one that's furthest along in evaluation, the one that I'd like to briefly touch on, is rapamycin. Rapamycin is a macrolide antibiotic, but it has potent immunosuppressive properties. It inhibits the cell cycle in late G1. It inhibits smooth muscle cell proliferation and migration. So not only does it inhibit cell cycle, it also inhibits the ability of these smooth muscle cells to migrate and proliferate into the injured area. And it is currently approved for use in renal transplant rejection. Now, recently reported at the European Congress of Cardiology is the Recoil trial. The Recoil trial looked at the use of a Sirolimus coated stent. Again, you're not giving this systemically. This is actually a stent that has this material bonded to it, and it's released over a period of time. And the importance of this slide is that if you look at the angiographic restenosis rate, we have never in the 2-decade history of coronary angioplasty and stenting have we seen rates of restenosis angiographically that are zero. So although this is a relatively small trial of approximately 220 patients, the impact is rather profound. So in the control group, those who received regular stents, the restenosis rate angiographically in follow-up was 26%. The restenosis rate with the treated group was zero. There were no deaths in follow-up. And if you look down at major adverse cardiac event-free survival, 97%. These are all obviously highly statistically significant, and this does bring potentially a new mode of treatment for patients with in-stent restenosis, as well as patients undergoing routine coronary angioplasty and stenting as well. But again, I think it's important to point out also that I've never in my career seen anything in medicine that is zero. So I suspect that this rate will increase with more patients, but clearly the impact that this will have on our practice is going to be rather profound, I believe. So in conclusion, as I said, coronary restenosis is due to several factors, one being mechanical. Stents have been very effective in eliminating elastic recoil and negative remodeling. There's also a biological issue which we are now addressing in the last several years. This is a wound healing process. Radiation therapy is the current treatment of choice for in-stent restenosis and has a very important impact on subsequent restenosis. But again, there continues to be restenosis even with radiation therapy. It appears that drug-eluting stents are very promising and that this may be indeed the answer to our problems with in-stent restenosis in patients who have undergone percutaneous intervention, as this patient has that was presented. And with that, I'll turn it over to Dr. Goldberg, who will be discussing the approach to this particular patient. Thank you.
Thank you, Dr. Dean. Well, this patient was treated with cutting balloon angioplasty and brachytherapy or intravascular radiation therapy. Cutting balloon has become popular lately to treat in-stent restenosis for a couple of reasons. One, the cutting balloon, which is a balloon with 4 microtome blades bonded to it, cuts into the plaque as the balloon is inflated. And with in-stent restenosis, this anchors the balloon so it doesn't slip or watermelon seed beyond the stenosis and is useful. In addition, there's some evidence that by cutting the plaque, more of that plaque will extrude through the stents of the struts of the stent, and therefore you can get a larger luminal result at the time of the angioplasty procedure. So this is an angiogram showing the cutting balloon being placed within the vessel, carefully at the distal part of the stented portion. And here you can see the cutting balloon being inflated. It's impossible to see the microtome blades except very up close. Here is the radiation therapy catheter. This is a beta radiation source using strontium-90 and yttrium. It was placed in the vessel for a total of about 3 minutes, giving 18 gray to the vessel wall. And here is the angiographic result after the angioplasty procedure. You can see that the vessel is a small caliber vessel, but that there is no stenosis in it, and there is good, brisk TIMI grade 3 flow throughout the vessel. And here is a before and after picture showing the angiogram before the intervention and after the intervention. We then turned our attention to the saphenous vein graft site, where you can see the stenosis at baseline. Here is, again, a cutting balloon, this time a 3.75 millimeter balloon, and the radiation source you can see right there. Again, delivering 18 gray to the vessel wall over a 3-minute span of time. Here's the angiographic result after we were done. Here's the area of the stented portion right there. And here is the before and after pictures. In follow-up, the patient 8 months later is doing very well. He's working out daily at the gym, doing vigorous aerobic exercise. He is free of symptoms and feeling quite well. With that, I'll turn it back to Dr. Dean.
I think we have time for a few questions. Are there any questions from the audience regarding either the patient or the approach or treatment of restenosis?
I'd like to direct my question to the issue of long-term results in rapamycin. When can we expect the follow-up studies to reassure us that this is a long-term effect? Is there any worry about leaving uncovered stent, which is my understanding occurs in some 30% of patients? Is this process that we have turned off short-term likely to be turned off long-term?
Those are excellent questions, and we don't have all the information. It depends on, if you look at the animal models of restenosis, there is a concern that perhaps with rapamycin or other drugs that we are, by inhibiting the process of rehealing, that we're only doing that for a period of time. That given a period of time that the vessel will proliferate to the same degree as it would have done without the rapamycin, we are just prolonging that period of time till that occurs. So in answer to your question, it may be that with long-term studies that we do see in-stent restenosis occurring again. It remains to be seen, at least in the humans that have received rapamycin-coated stents, whether that's the case or not. In answer to your second point, there is also a concern, since we are inhibiting the healing process, that we are exposing the stent struts to blood for a longer period of time, and there is a concern. The FDA has actually prolonged or increased the number of patients that are required in these trials, and their follow-up has been lengthened as well because of the concern that this stent, because it is not healing properly, there may be late events such as acute stent thrombosis, for example, which has also been reported, as you're aware, in patients who've undergone radiation treatment. So the use of antiplatelet drugs for prolonged periods of time will probably be necessary with these drug-coated stents, as it is also necessary with radiation treatment that patients receive. Any other questions? If not, then I'd like to thank all of you for your attention, your good questions, and we'd be happy to see you back at another Regional Heart Center Grand Rounds in the future. Thank you very much.